Good afternoon, everyone. Thank you, Mauro Bridges and the organizing committee for the opportunity to participate. Just like the other ones, I feel honored to be part of this 2 to 3 day project with a high level discussions on challenges at managing HIV infection in different settings, but with information that certainly affect us all. Everyone has a case. You remember when such a setting, was the same. But now in late afternoon or after a long day of discussions, I am bringing a case where we are going to get back to many things we discussed since early morning to now in a real life case. I would like to thank a great friend and resident who forwarded me the case. She works in Curitiba, Parana, in a setting of HIV care services in an underprivileged region. We will realize that there are still lots of difficulties related to this. So this particular case, this is the history of a woman, a transgender, 48-year-old transgender woman who comes to the clinic with a HIV positivity test. She's just been diagnosed with HIV. At the time of diagnosis, she had a high viral load of 6 logs and a CD4 count low. She denies the use of previous therapy, so that she wasn't using any therapy for gender or anything. She had no abnormalities whatsoever in physical examination despite the CDA count low. She was asymptomatic. She had not been on PrEP. We asked if she had not been on PrEP. However, in the past, she had a mood disorder. She would smoke. She smoked both tobacco and marijuana and occasionally cocaine. She had been diagnosed with hypertension for 2 years and she was using losartan. I mean, she confessed she wasn't very adherent to the drug. It depended on having it, their administration, and even when they have it, it was difficult to take. In initial tests, there we see the result, a discrete blacketopenia and a 1.3 milligrams per deciliter creatinine with a felt filtration rate of 68. Normal urinalysis, no proteinuria, and her BMI was okay. I mean, we have no resistance test pre-treatment because it is, according to our national guidelines, she wouldn't meet the criteria. So the question I ask you is what contamination of antiretroviral would start in these settings? There's no much difference from what is recommended in our guideline. There's no major singularity. Perhaps it's just a matter of who would like to start on tenofovir, who wouldn't. But at that time, in that setting, the colleague decided to start a therapy on tenofovir, TDF, all of these. I mean, TLD, SMX, TMP, and this regimen was prescribed. In the first follow-up visit, I mean, she was requested to come back about 4 weeks later. She came back. We had a new creatinine test because our colleague was concerned with starting therapy with TDF, and it was a high blood pressure patient. The creatinine was somewhat, there was a time of 0.15 creatinine, and then we understood that could be this tubular secretion by the use of raltegravir. But if we add 0.15 in creatinine, we have a discrete reduction in glomerular filtration rate to 59. We still didn't have other marker to assess the renal function that we could use as cystatin. This could be a regular case, cases such we see all the time. But one thing I would like to highlight, and now we're talking about key populations. It's not by chance that we have the definition of key population. The WHO establishes as key populations with a certain specific characteristics that turns the management prevention very special. We have to adjust it. We have to adjust to the needs. We have evidence that are not always applicable, but with this we must understand better, prevention, as it was mentioned by Beatrice, works so that we can be successful. Among these populations, we have the patient that we are talking about. Getting back to it, so in 4 weeks she came back. There was no mismatch. We kept tenofovir, disoproxil fumarate, etc., and mismatchings started to appear. Mismatches happen in our service. We have several patients to serve. We not always realize a patient that should be there and didn't, and it comes backwards. A patient in 3 months, that's when we had the very first viral load from 6 logs to approximately 2 logs, and then 3 months later she didn't come to the visit, but she had a form to do viral load, and she came back 3 months later with the same viral load. So on the tenofovir, lamivudine, dolutegravir, Bactrim prophylaxis, and in 6 months she had this issue of a lower viral load. When she came back with this latest viremia, she was symptomatic. On the day of her 6-month results, she would no longer be asymptomatic, and there was something new. She said she had cough, night sweats, fever, chest X-ray abnormal compatible with a TB diagnosis, and sputum molecular test compatible with TB positive, sensitive to. Would you stop or switch her antiretroviral therapy because of TB? I don't think so, but would you switch the antiretroviral treatment? If the virologist was not detectable in 6 months, will I need to treat TB before? Discontinue antiretroviral therapy. No one does, and we no longer does. We fight against it. Those would be very special situations, or where we would agree to do that. But when we step back in time, the decision as to when to start antiretroviral therapy in TB patients, that was the focus of discussions later on. But today we know that when the patient has tuberculosis, starting earlier is better than postponing the beginning, except cases such as central nervous system infection, since the immunological restoration syndrome with a rigid skull gives us a very high risk of death for intracranial hypertension. But think about tuberculosis. Some of the studies taught us that we do not need to wait 8 weeks to begin therapy. We can start it earlier on. Studies recommend that you can start up to 2 weeks of HIV treatment. You would start antiretroviral therapy, particularly for those patients with the CD4 under 50. That is not the case of our patient, because with the viral load decrease, although not suppressing, her CD4 count went up a little bit. You might realize it's at about 250, but we would not postpone the treatment. Another issue, we will not postpone. She's already on tenofovir, lamivudine, tenofovir, and now we'll start the TB treatment. The complication here, what left this colleague uncomfortable, was the fact that the patient had not suppressed viral load. She had a low viremia. She had a viral load between 100 and 200, and we could not have a resistance test done there, given the figure of viral load. But what did you decide? They decided to increase the dolutegravir dosage, correcting for DDI interaction with rifampicin, and keep the same treatment, monitoring viral load without any other change whatsoever. Bringing it back, what Dr. Alvaro already showed it this morning, inspiring study data. This study showed that there could be the possibility to safely and non-inferiorly, as we do with the 5 variants, to use the dolutegravir in 50 milligram every 12 hours associated to a backbone, as we did. When we look at the inspiring study data, this patient is well represented. When we look at viral load, high viral load, as it was her initial viral load, is happening to 60% of patients. The same way pulmonary tuberculosis, this is what she has, also well represented in the study, and TDF, 3TC, also well represented in the study. So we could do it. However, because of the detectable viral load, although low but persistence, couldn't get undetectable viral load after 6 months, bothered us. Of course, we talked to her. We asked about adherence, the best recommended, respecting the possibility, because some people can't take drugs every day. But all the time she said she was taking the drugs. But we always suspicious of a poor adherence. On the other hand, when we look to the literature and after the talk by Dr. Ricardo, we keep thinking that perhaps there will be few, we must be fair, there are few reports of acquired resistance to triple therapy with dolutegravir, but there are. And if we look at these very rare cases, it reminds us of our patient. So the very first case I bring is a case of a patient with co-infected HIV TB early in therapy. These patients have the clinical characters of a worse time to clean. A lot of virus, very high viral load, non-B subtype. Remember, I'm from Parana. We have a lot of subtype C, very much so in Rio Grande do Sul, but she could have an HIV by non-B subtype. Drug-drug interaction. I have a lot of virus. I had an additional difficulty, which is drug-drug interaction, opportunistic diseases, etc. So it's a more stressful scenario for virological control. And this goal is a patient co-infected HIV TB using a triple dolutegravir regimen using rifamycin to treat tuberculosis, corrected according to the recommendation of dose adjustment, and she had acquired resistance. The second case must be the case. I think it was a very first well-documented case in the literature. It was published in New England 2019. This is a patient with an unfavorable scenario, non-B-type HIV, tuberculosis, high viral load, drug-drug interaction. There are very well-documented cases, selection of resistance to a triple initial regimen with dolutegravir. The patient was not on rifampicin, was rifabutin in his regimen, which also includes DDI, but doesn't require dose adjustment different from what we do with rifampicin. In addition, study Voisin has always been mentioned by Dr. Monica. This study assessed patients who failed to non-analogs with the two research arms. If we get the arm with those who failed, who had good adherence, and even though had the viral load above 100,000 copies, here they tested four salvage strategies. Dr. Monica had already showed the virological studies. I will not mention that, but what I meant to show you that even in the best results, even in the arm with the best results, which was the arm on integrase inhibitor, when we looked who failed, the highest failure risk were in TB patients. In this study, there were 3 times higher risk of virological failure in those TB patients. Considering everything we said, this is a more challenging patient to treat, given all of these characteristics that had been mentioned. Integrase inhibitors are absolutely essential in HIV treatment. Dr. Ricardo started his talk talking about the importance of dolutegravir in treating HIV throughout the world. And as Brazilian, I also see the importance of dolutegravir in our country. And we needed to be active and available and easier to use for a long time. This is the reason why we must understand what is the best settings and in what settings this drug works best, so that in the future we will not find it difficult to use these drugs in patients who actually require integrase inhibitors. When we look at drug-drug interaction, this is the website we mostly use to check it out at the Liverpool University. It shows the pathways metabolizing those drugs. So if I look at integrase inhibitors, rifampicin, I understand what kind of drug-drug interaction I might have, the way that it metabolizes, and under the clinical standpoint, what changes I should make. We have very few data. We have more information. Dr. Alvaro mentioned this morning, studies in progress, so that we can better understand how to deal with those two infections, which we know in our country we still have a lot of TB, and it's very unfavorable, the occurrence of TB in people living with HIV. And in this setting, we have something new. Now we have data from Radiant study. showing that the virological response at week 24 of people with a HIV, treated HIV with the dolutegravir-based regimen and TB with rifampicin and used dolutegravir QD, there was no difference under the virological standpoint of using a BID. The same thing that Dr. Alvaro said. The virological response in general was lower than what we expected, and certainly raises a flag. They have not taking the drug is more important than not taking the drug, but somehow perhaps thinking about the heterogeneity of patients, and even in cases of co-infection, TB and HIV. Cases with acquired resistance diagnosed TB at opening, so very high viral load, non-B subtype, tuberculosis, disseminated tuberculosis, a lot of immune suppression. If I have a later TB, the scenario might be a little different. I might adjust the therapy. I have undetectable viral load and I still have pulmonary tuberculosis. Perhaps we should consider this. I don't know. We might bring this to discussion. Perhaps this data is much better for us to be able to tell patients that who missed doses or could not take BID that everything can work out still. I mean, define the treatment. I mean, perhaps we would need more data. Finally, I wanted to remind you our distress of leaving tenofovir as third agent or treating patient with a dual therapy when we do not have enough data for dual therapy with a dolutegravir 3TC and with tuberculosis with viral load not suppressed yet. Some distresses come to our mind, and it summarizes that when we say that the dolutegravir resistance is rare, but can be developed in individuals in B HIV subtype, high viral load and low CD4 count cell, insufficient adherence. Patients who are not adhere to patient drug interactions, and this is the importance of rifampicin, and the combination of factors could be the reason for some not so favorable outcomes. The good side is that this history have a happy ending. After supporting the patient, inviting the patient, calling and using primary care services professionals, bringing her to the center, fetching her home to the center, we managed to work the tuberculosis. We could not perform a resistance test, but she was treated with a triple therapy, and glomerular filtration rate in the end was quite good. We still have several gaps with regard to tuberculosis. If you haven't read it yet, I recommend you should. It brings a lot of insights, things that we don't know, and my solidarity to my pediatric infectology, because this article talks about if we in adult infectology understand that there are knowledge gaps in TB treatment to those living with HIV as an adult, pediatrics feel it even more and harder. So we hope that in the next few years studies will answer these questions. And for those who don't know, there's a document published by the World Health Organization with suggestions on how to act with the different key populations with their particular challenges and how we can adjust to offer a better follow-up. Thank you very much for your attention.